Welcome back for all of you that already joined the first session. Last week we have here the talks from two distinguished speakers, Dr. Jusung Lee and Dr. Widyaningsih. And tonight, in this evening, we will have the session for question and answer. So from the previous session, I think we have some question and we will discuss about that. But first of all, I would like to say hello to our speakers. How are you, Dr. Jusung Lee?
Hi. Yeah, I'm good. Thank you for asking. How are you?
I'm doing fine, thank you. So, Dr. Vitri Widyaningsih, how are you?
Hello, I'm good, thank you.
Okay, and also welcome for all the participants. I can see that a lot of the participants are the students. So I hope that this session also will be benefit for the student as well to learn about specific methods in statistics that allow us to estimate the effect of the program or policy to particularly in maternal health. Okay, so let's start the first questions that we had. Let me share some summary. Okay, so we have some question from the participants. Okay, the first question is from Lely Tripangesti. So the question refers to Dr. Vitri Widyaningsih about the lesson learned from Texas maternal healthcare for Indonesian context. So please, Dr. Vitri, would you like to elaborate some answers for this interesting question, please?
Yes. Thank you, Ari, for moderating this session, and thank you for the questions. I think when we're looking at what Jusung presented last week on how Medicaid expansion has potential beneficial effect to women, not only in the maternal period, but also women in general. What we can see from that is actually the benefit of actually expanding the financial aid or financial program, especially in the form of social health insurance, not only in the lowest or the poorest quintiles like what we have now. So in Indonesia, our program for social health insurance is particularly targeting the poor, but we see that this effect is actually also beneficial not only to the poor, but also to the higher socioeconomic groups. And this is actually, we see as well, so in one of our other analysis in another paper, we actually try to capture how health insurance membership by different socio-demographic factors. And if we see from the point of view of socioeconomic status, the shape is actually a J shape. So you see higher prevalence of social health insurance membership in the poor population, but then it gets lower. So the middle one, so they're not really poor but not rich, they actually have lower social health insurance membership. And then you see higher again as the social economic status increase. So this middle population is actually the one also probably need extension, or in the case of United States, expansion of maternal health insurance, and Indonesian population also can benefit from that. And hopefully right now we see increasing healthcare membership. However, we still need to see how this increase in healthcare insurance actually also increase healthcare utilization. That actually one of the things that we need to see as well. I hope this answers your questions, Lely. Thank you.
Thank you. Yeah, so I would like also to elaborate this question for Jusung. So what lesson learned that you can take from the analysis from Indonesian context to US context, please?
Yes, I think both studies show the benefits of having insurance coverage. So from my perspective, this kind of social health insurance system or the comprehensive coverage policy is very important to benefit the general population, so not just the specific population, but the general population to have access to care. We see that there is a discrepancy between health insurance and the actual utilization of healthcare, but we still have some problems there. But the first step is to have insurance coverage, and then if there is any issue in access and care, we can look at those problems. We can fix that. So I think the first step is to have a health insurance. So that is the most important from my perspective.
Okay, thank you. Thank you very much. Okay, now we move to the second question, please. Yeah, from Matthias. So it's question for you, Jusung.
Yeah.
Yeah. So would you like to answer this question?
Yeah. Thank you for the question. I'm not actually sure if there is any policy that regulates individuals to receive care during pregnancy or after pregnancy. But we know that at least public health and reproductive health communities all strongly advise individuals to receive some kind of preventive and essential care during the pregnancy or after pregnancy or before pregnancy to prevent any health issues, complications associated with pregnancy. So, but even after being insured, the people still have barriers, right? So those barriers could be financial or structural. So financial barriers, we can maybe reduce some premiums, or we can provide free or low-cost reproductive health services to low-income individuals. That increases the access to care. Also, structural barriers have a very wide range of things, such as geographical barriers. Usually, people living in rural areas have less access to care because rural areas don't have enough clinics or hospitals. Also, individuals don't have transportation or don't have enough time. So there are a lot of barriers. But I would like to point that cultural competence is very important, especially in the US. We have different race ethnic groups. We have people coming from different countries around the world. So we have a lot of culture, a different culture. So understanding the culture, different culture of patients is very important in the healthcare settings. Also, I would like to say that a campaign for the awareness of the general public about the importance of routine checkups or receiving essential care is very important. So maybe some people just don't understand how important that is. Yeah, that is my answer to the question. I hope I addressed some of the questions.
Thank you, Jusung. Vitri, would you like to add about that, about this elaboration on the answer for this question, please?
Yes, thank you. And I'm going to share maybe from the Indonesian perspective. As for regulation, our policy, actually, we don't have exact policy with reward or punishment, but we do have recommendation. And prior to 2016, WHO also has a recommendation for women to check their pregnancy regularly and we adopt that. So in Indonesia, a woman is considered to have regular pregnancy checkup if they have the antenatal care for at least 4 times during their pregnancy. So once during the first trimester, and then one during the second trimester, and at least twice during the third trimester. And in 2016, WHO recommend an increase in antenatal care. So instead of having only 4, the recommendation is actually for a woman to have at least 8 times. So this 8 times is basically based on weeks. So if we summarize, it's once during the first trimester, and then 2 times during the second trimester, and then 5 times during the third trimester. And it's increased by the time a woman reaches their term. So reaching the 40 weeks is getting, the frequency is getting higher. So woman comes to the antenatal care visits more regularly. However, as Jusung mentioned, in Indonesia, it's actually similar. There are a lot of barriers. So as previously in the presentation, we mentioned at least we have physical barriers. So women actually don't have the access to healthcare. And for Indonesian population, it's especially in rural and remote area. And we also have the financial barrier. So women cannot access the healthcare because of financial constraint. And this is not only due to the medical aspect or the medical cost, but also for the indirect cost, because they have to go or travel to the healthcare facility. So this is something, as Jusung mentioned, also something that we need to work on. I agree with Jusung that cultural competency is very important to increase awareness about this problem. And this is the same thing with Indonesia, because we also have different ethnicity. So it's very important to also address the cultural competence as well. Thank you, and I hope this answered the questions.
Okay, thank you very much. We still have some questions from the previous participant of the first session. So please. We have question from Victoria. Yeah. Okay, I think it's for both of you. Yeah. Most of Indonesian villages are still rural. So I think it's also in the context of US, you have the similarity. Yeah? In Indonesia, villages are still in rural area, and then it's difficult to assess the technology, and also there is a limited health officers, limited healthcare workers in the area. What do you think about how to increase awareness of pregnant women, particularly to use the health services for them by using health insurance? So please, Vitri, would you like to start about that?
Yeah, thank you very much for the question. Yeah, we do have a lot of barrier, and it's particularly in rural area, but also we have some barriers in urban area as well. Regarding the technology and limited access to health officers, as presented in the presentation, we actually see that when you're sending the health officials to the village or to the rural area, so it's going to reduce the barrier. And we see that the main improvement was actually observed in the rural or more or less developed region compared to the more developed regions. However, when you're thinking of financial burden, or when you're trying having a program that trying to reduce financial barrier, the supply needs to be there first. So the health officials, healthcare facility needs to be there first, and then you are able to actually provide incentives or social health insurance to improve utilization. And that's also what we see. So in Indonesian context, in the beginning, the government tried to improve physical access. In our context, we have the village midwife, so sending midwives into the village. And then after that, we have the improvement of awareness. Although from the analysis, we see that that's not really effective, actually, the program. And then in the latest one, we have programs that actually reduce financial barrier. And if the first program, the one reducing physical barrier, is more effective in the rural and remote area, the program that actually aim at reducing financial barrier actually more effective in the urban area or area that are more available, so they have availability of technology and also health officials as well as healthcare. So this is, I think this needs to be balanced. So you really need to improve supply in the healthcare side, and then after that you will be able to improve awareness, and then when they're being aware and then access healthcare, you also need to reduce the financial barrier so that they will be able to access the healthcare. So yeah, the healthcare service cannot be improved only by providing social health insurance, but there are other steps that needs to be taken care of first. I think that's
Thank you. Yeah,
Indonesia.
thank you, Vitri. Yeah. So I would like to invite also Jusung to give some views on this question based on maybe the lesson learned from the US context, please.
Yeah, I'm going to talk about especially the rural-urban difference. There is a lot of research going on looking at the difference between rural and urban areas in terms of many health indicators for access to care, but still there is a problem there. So I think the state or local government role is very important in this area. So the local or state policies should be supportive of initiating or implementing some kind of technological support, such as telemedicine or remote care. So that could reduce some of the barriers. Also, in terms of the awareness, well, I presented about the South Carolina statewide initiative. What they did is, so they also now doing is a campaign of the public about the available services or the way to access care. So many women want to have those services, but they don't have enough knowledge where those services are available. So it is very important for policymakers or the public health community to let them know where the resources are, so they easily get those resources. So I think, in the difference between the rural and urban areas, especially government role is very important, and also government should implement very supportive policy to implement new technology. So that really facilitates the increasing the access to care.
Thank you, Jusung.
Yeah.
Okay, I would like to invite all the participants to send question in the chat box, or you can raise hand and then I can give opportunity to ask question directly to the speakers. So please, but maybe waiting for that further questions. I have some question, particularly because most of the participants in this evening or in this morning are students. I would like to ask both speakers about the indications to use the segmented regression analysis, that's for Vitri, and difference in different technique of analysis for Jusung to show the effect of the program implementation or policy implementation. I think maybe some of the participants have not really learned about the first session, so I can give this opportunity for both of you to show the indication of the two different techniques to show the effect of policy on maternal health particularly. So please, maybe Vitri, you can start, and you can show as well the PowerPoint from the previous to show your answer about that. Thank you.
Yes, thank you, Ari. And yes, I'm going to share the presentation before my previous presentation. Okay, so the segmented regression that I use in this analysis is actually a development from what we call interrupted time series. So maybe some of you are already familiar with that. So basically, interrupted time series is an analysis that you usually conduct at the community level or population level. And let me share with you. Okay, so have you seen my screen already? Yeah, I think I can. Okay, and I will make it like this. So here, this is actually a picture describing interrupted time series. So what we call interrupted time series because it's actually an analysis that you conduct in a longitudinal data. So you have data of a population over a certain period of time. In this case, we have data from 1987 until 2012. And then in general, we want to see the trends. And interrupted here, it actually means because we have something happen in that time. So the trend is, for example, the trend should be, for this one, it should be going down, for example, or here, sorry, I will show this pointer. So it should be going down, for example, here. And then for here, it should be going like this. So you see, this is like an imaginary line. If we consider this constant over time, if there's nothing happen. But then there's something happen there. And this something happen can be natural experiment. So something natural like natural disaster or policy can be something that happened without the investigator actually assigning it. So it's what we call natural experiment. So here, because of the intervention, there is an interruption in the trends or interruption in the time series. So here you see the line should be going down, but instead it's actually going up. And then here, this line should be like this. So it's just following this line and without this sudden change. But there is actually a sudden change or sudden increase. And then there is this line, and this is representing the increase in healthcare utilization for this analysis. And then there is something happened here, and then the line just going up with a different slope. So this is the basic of interrupted time series. And as for segmented regression, it's actually when we're trying to apply the same thing, but at individual level. So interrupted time series, usually you do it at the population level. But because for this analysis, at that time, we want to ascertain or evaluate some of the effects of individual factors. So instead of doing interrupted time series, we do what we call segmented regression. So basically, it's just a regression, but the regression is actually segmented. So you have, it's similar to interrupted. So you have segment of regression. So actually you have 1, 2, 3, 4 segments, and we call this segmented regressions. So here you will be able to see whether the interruption, it can be policy or other things. So whether this interruption is actually changing the slope. So this is the slope, meaning that it changed the trends, or whether it's actually changing the intercept here. So the intercept actually describing a sudden change, so immediate change. For example, you have intervention to increase tobacco tax. And then because of the increase in tobacco tax, usually there is a drop in sales. So that is what we call intercept change or immediate change. However, if the intervention is actually, you think the intervention will influence trends, so it influences gradually, you don't see immediate change like this, but what you see is the change in trends or the change in slope. So in the case of Indonesia, and I will go to this slide. So in the case of Indonesia, and this is the same thing, but we do it at individual level. So you see that in the first segment, some of the utilization actually increased, but very slowly. And then after the implementation of village midwife, it increased, especially here in the second groups. And then it increased it's increasing more here when the social health insurance start. So the increase here is more pronounced when you compare this to the previous years. So this is what we call segmented, and we do it basically based on regression. So it's actually a type of regression, and you just have segment and you just provide interaction in it. I hope that explained, Ari, about segmented regression.
Yeah, thank you very much. Okay, please, Jusung, you can also elaborate about the indication for difference in difference technique.
Yeah, I think this is really illustrates how the difference in differences approach works. So when we are looking at the relationship between exposure and outcome, we really would like to see the causal relationship. So A causes B, but with the secondary data set, we have limitations. In observational studies have inherent limitations. So difference in differences just mimics experimental design to show some kind of causal relationship, although it is not 100% causal relationship. So in this study, I had 10 years of data from 2011 to 2020, and then the policy intervention was implemented in 2018. So if we want to look at the impact of intervention, we have to see the pre-policy period first. So if the trend in the pre-policy period is different between two groups, we cannot say the after policy effect because they are already different. So first thing is we need to do is to check the parallel assumption test. So I looked at the trend between groups if they are different before the policy intervention. So here I used the so-called placebo test. It is just using the pre-policy period. I subjectively choose some time point, and then I make a fake treatment and control groups and compare them. So the result is this estimate. So if that is significant, that is indication of violation of the parallel assumption test. So since the parallel assumption has been met, we can proceed to look at the policy effect. So how this DID does is, for example, the control group has a pre-effect and post-effect. So we differentiate between pre and post for the control group. And the same thing for the comparison group. Comparison group has a pre-effect and post-effect. We differentiate the effect. So we have two differences. So we again differentiate those differences. So we can get the one estimate that is a difference in differences. That is a policy or intervention effect. So yeah, this changes. DID estimate is the final estimate, the difference between two differences. So there was about 6.4 percentage point increase in intervention group compared to comparison group. So again, as I said, this is not a causal relationship, but it mimics at least the experimental design. Yeah, that is, I think, a little bit explanation of how DID approach works.
Thank you, Jusung. Yeah. We have another question from a student here, from Dilma. The question is about, I think it's also for Dr. Vitri. And there are so many maternal health programs, particularly in Indonesia. However, if we had look at the maternal mortality rate, it's not fallen significantly. We have many maternal and child health problems, and the government also have done several programs. And Dr. Vitri already also analyzed 3 programs related to maternal health in Indonesia, and it doesn't work optimally. The question is, what should we do to make the maternal health program in Indonesia doing well? Please, Dr. Vitri.
Yeah, thank you very much, Ari. This is also actually one of the things that become a question, because we see increase in healthcare utilization. Program is shown to be effective in increasing the healthcare utilization, but so this is kind of like a short-term outcome, but we don't see what we want to see, the long-term outcome, which is reduction in maternal mortality or reduction in maternal morbidity, because we see that morbidity is also increasing, whereas mortality rate is not decreasing at the rate that we want it to in Indonesia. One of the main point that we, based on the review of literature and then analysis that we did, as well as looking at the policy that happened, one of the problem is actually the quality of maternal health care. So we see improve in access, but we don't really see how is the healthcare provided to the woman. So how is the quality? For example, we did an analysis on antenatal content. So in Indonesia, the recommended antenatal care is to for a woman to receive at least 9 components. For example, they have to be getting their blood pressure checked, and then getting their weight, their height, and then having some blood works to check for anemia, for example, and then also being checked for the progress of pregnancy by ultrasound. But that is something that we don't see for every woman. So antenatal care content, and this is one other analysis that we did as well as part of the dissertation work. the utilization increased, but the quality is not increasing at the rate of the healthcare utilization. And when we look at deeper, and this is from reference as well, we see that some of the problem is actually because we don't have the distribution of healthcare provider is still not similar across different area in Indonesia. So this is one problem that we need to address. First is to address the lack of similar distribution of healthcare officials. And then the second is to improve healthcare quality, especially for maternal period during pregnancy, delivery, and postpartum. Another thing that we also see from several projects that we did at Maternal Health is that women is usually okay when they are pregnant. However, when they're giving birth and then postpartum, we see drops in healthcare visits. So our visit for antenatal care is actually pretty high. For Indonesia, it's above 70%. Women actually have access to antenatal care. However, in addition to quality, after the woman is giving birth, they lack access and they no longer visit healthcare facilities. So it really drops under 40%. So this is also the things that we think contribute to the high maternal mortality, because most of maternal mortality actually happen during partum, so during delivery, or postpartum, so after delivery. So this is also some of the gaps that we still see. So in addition to improving quality and then distribution of health providers, we also need to improve healthcare utilization, particularly in the postpartum period for Indonesian women. I think that's several things that still needs to be done in addition to improving awareness as we discussed before. Thank you, Ari.
Thank you. Yeah, I would like to invite anyone that you would like to raise some question directly. You can do in English or in Bahasa. I will help with the translation. Okay, just raise your hand if you have the question. Okay, while waiting for more question, I have also some question again to Jusung. In the first study, you found that insurance coverage is increasing significantly, but not persistently improve the access of the care. So the question is, why does that happen, Jusung? Please.
Yeah, that is also, thank you. That is also my question. So I'm curious about why the insurance coverage, improved insurance coverage does not translate into actual access to care. So from my perspective, after the ACA Medicaid expansion, many states opted in that policy. But during that time, some states have also implemented their some state-specific policy changes, but there are some also issues. Medicaid patients do not have access in the same level as others do, because some healthcare providers don't receive Medicaid patients. Even though they have insurance, they don't have access. Yeah, I think so. Also, some states implemented work requirement for Medicaid eligibility. So those things may prevent individuals from freely going to the doctor's offices. Also, the policy prevents individuals from easily going to doctor's office. So I'm not sure what's going on in the community, but at least I see there are some issues medicated patients do not have actual access to care, even though they have insurance. So that is problematic. The policy intervention doesn't really achieve its goal to improve the actual access to care. So as I said before, the first step is to have insurance, but insurance does not mean the actual access care. The ultimate goal is having care, necessary care, preventive care. So I think that is a problem. Also, usually after policy intervention, during the short term, that is effective. But as we have seen in the study, there has been fluctuation over time. So we need to pay attention, continuous attention to policy effects. So if the policy effects are diminishing or decreasing, there is also an issue. So we have to make sure that policy effects are continuing and sustained.
Thank you, Jusung. Okay. I have also a question for Vitri. Your analysis shows that there is a gap of utilization, particularly in outer Java and Bali. Even various maternal health programs have been implemented. Why does that happen? What contextual factors related to that phenomenon, please?
Yeah, thank you very much, Ari, for the question. And we actually see some improvement, and this happened in all area of Indonesia and also by wealth. However, in 2012, we still see that there are indeed disparities, and the disparities happen not only by region, Java, Bali, and outside of Java, Bali, but also by wealth as well. So we actually did an analysis on this using what we call decomposition analysis. So what we analyze, we're trying to capture what type of programs or what type of characteristic that actually influence the differences between the region as well as between the wealth categories. And what we see, because in the decomposition analysis, we actually have two main parts. The first part is differences in characteristics. So the woman living in Java, Bali, and the woman living in outside of Java, Bali, they're different. And because they're different, there are also differences in what we call differences in effects. It's the difference that they have because of their characteristic, the way they behave to certain intervention, or the way they behave when they have when they're actually experiencing the same thing. So in the case of maternal health care, for example, a woman in Java, Bali is actually they're more educated. So we know that more educated women actually, they tend to access healthcare more. They're also from the higher socioeconomic groups. So women in Java, Bali, they have lack barrier in physical barriers. So they actually, the distance to healthcare is actually not something that a problem to women in Java, Bali. So these differences in characteristic actually affect that. However, we also still see differences in effects. So although the woman is actually the same woman, like the same woman from the same groups of wealth or the same woman with the same level of education, if they live in Java, Bali, and if they live outside of Java, Bali, there are still differences happening to them. For example, and this is also what we see, for example, in the pregnant, particularly this is happened in the delivery. So even though you're highly educated, even though you know that you have to go to the hospital, if you're living in outside of Java, Bali, and you're actually have you have difficulty in accessing healthcare, you cannot access healthcare. So that's one of the things that we also see using the decomposition analysis. This is an approach famously known as Oaxaca blinder. So we're actually seeing those effects, so differences in characteristic between the women, as well as the differences in the way they react whenever they have something happening to them, because the place they're living in. I hope that answered your questions. Thank you.
Thank you. So we hope that for the next webinar, we can learn as well about the decomposition analysis methods. Yeah. Okay. So I think we have still time. So I have still a question for both of you. That's related to the further research needed in relation to this healthcare utilization in maternal health. Yeah. What kind of research question that do you think important for the future research? So please, maybe Jusung, you can start with that.
So in my study, in terms of the South Carolina study, the South Carolina have experienced the low, the poor reproductive health outcomes, such as unintended pregnancies, teen pregnancy. So that was a very big problem in the state. So one of the goals the state has through the initiative is to reduce unintended pregnancies. So to do that, women are well advised to use effective birth control methods, such as long-acting reversible method. So in my study, I didn't look at those indicators. So that is very important. Accessing to care is important, but beyond that, the state has more goals to achieve. So the birth control method use is very important for healthy family planning to avoid unintended pregnancies. So in the next study, I would like to look at those indicators if the actual access really also had impacted the birth control method use, and also not just the use of the birth control method, but effective method use. So that's something I'd like to look at in the future. Also, in the Medicaid expansion study, I looked at just a few states in the southern part of the country. So I would like to expand the study to include states across the country. So how that effects look like across the country. Yeah.
Okay, Vitri.
Sorry, I was still muted. Thank you. Thank you for the time. I think one of the important thing, and this is from Indonesian perspective, was highlighted by one of the questions, like we see increase in utilization, but we don't really see increase in maternal health, which is depicted by the still, although maternal mortality is decreasing, but it's still not as at the rate that we want it to. So one of the main thing that we need to, I think we need to address or to evaluate is how is the quality of maternal health care that we have, because that's one of the gap that we see when we think of utilization, but it's not improving healthcare. There must be something there. So how is the implementation? What is the quality? What is needed to improve those? That is something that is very important. Another one is also highlighted by the question as well. I think when you look at Indonesia with the extensive amount of island, rural and remote areas, so we really need to also focus our attention to the remote and rural area. how to improve utilization there with all the cultural barrier. And this is something that may be beyond secondary data analysis. So moving, not only, well, not really moving, but also including, we're trying to have a research that also includes those social and contextual effects. So having like a mixed method research on this area is something that really influential, I think, for the recommendation to the policymakers.
Thank you. Okay. Okay. 9 minutes still for us for the question and answer. I would like to invite the participants if there is a question from you, a question from you. Please, would you like to raise your hand? Okay, and then I have the final question for both speakers. What do you see about the potential research question that can be compared between Indonesia context and USA context after you learn each other from your presentation? From Vitri can learn as well from Jusung, and Jusung learn from Vitri. So that I think it's good to see whether there is a potential research question that can be further studied between US and UTSA. So please, Vitri and Jusung. Jusung, would you like to start?
Yeah, I see a very interesting result from both the studies. So also there is a similar policy going on in two countries. So I'm just thinking about comparative studies between two countries. So we just looked at individually some indicators with data sets from each country, but if it's possible, I would like to do some comparative study. But I don't know how to do that, but I'm just thinking that so maybe we can develop the study further in the future.
Thank you, Jusung. Vitri?
Yeah, thank you, Ari, and also Jusung. I think I'd like to highlight similar thing with Jusung because we actually have similar themes. So regarding financial barrier, so improving access to healthcare. So that's one policy that is similar between Indonesia and USA. However, if we want to make a comparison between the two countries, we will need to take a look for the indicators, variables, and the data set that we have, and then identify which data set that we can use, which variables that we can actually compare as well. And I think one of the important thing as well is like we have similar challenges. For example, how to address rural population, and this is both in United States and also in Indonesia. And then the second one is how to, in Jusung case, how to improve the utilization after healthcare insurance, and in our case, how to improve healthcare outcomes, so health outcomes after health insurance is already achieved, and then we have healthcare utilization, but we still don't see the effect on health outcomes. So maybe those are some of the things that we can discuss together further and see if we can come up with the same research question for further collaboration. Thank you.
Thank you, Vitri and Jusung, and everyone who participated this session. I think it's time to wrap up. I think we learned a lot from the two sessions, the first session last week and this evening. So at least we learn about the statistical technique to be used for estimating or modeling the effect of policy to maternal health. And then we also learned about the problem of healthcare utilization in terms of maternal health services in US and Indonesia. And we learn as well about the potential issues that can be studied in further in collaboration between UTSA and UNS. So thank you very much for joining this session. So we hope that we can arrange another webinar series in 2022. So we're looking forward for that. Thank you very much. Have a nice day for you in San Antonio, and have a nice evening for all of you in Indonesia. Thank you very much.